Welcome to the Putting the Public into Health podcast by Dr. Richard Pan. As we face one of the greatest public health disasters in the century, this podcast will address questions and issues from you, the public, about the COVID-19 pandemic and its impact on people's health and lives. I am Dr. Richard Pan. I'm a physician with a background in public health, and I'm proud to represent the people of Sacramento, Elk Grove, West Sacramento, and parts of Sacramento County in the California State Senate. I want to share with you important information and stories to help each other during this difficult time. County public health officers are on the front line of halting the COVID-19 pandemic. I am pleased to have Dr. Erica Pan, interim health officer of Alameda County, join me today. She is a specialist in pediatric infectious disease and previously served as director of the Public Health Emergency Preparedness and Response Section in San Francisco. While I admire her numerous accomplishments, we are not related, though we share a last name. Thank you so much for joining me, Erica.
Thank you very much for having me.
So as a physician, why did you decide to go into public health?
Sure. I think I became interested as early as my undergraduate years. I took some interesting classes in health policy and, started to have an interest even in undergraduate about being a doctor and being able to take care of patients, but also being able to step back and look at the bigger picture, and had some interest in health policy. So then when I applied to medical school, I actually applied to combined MD and PH programs to get my master's in public health degree at the same time. So I actually attended an MD and PH program at Tufts University, where I was able to do my master's in public health kind of interspersed over the 4 years of medical school. And actually it really helped me get through some of the basic science years to be able to have some public health classes in between as well. And again, think about the bigger picture, thinking about individual patients, but also the larger community.
Great. And, I think really thrilled that you decided to do public health. Now, in the Bay Area, the health officers were among the first, actually probably the first in America, to declare shelter-in-place orders for COVID-19. In fact, this action prompted counties like Sacramento and the state to do the same about 2 days later. New York, which acted only a week after California, suffered many more deaths with, we saw in the news, with hospitals and ERs being overwhelmed and funeral homes. So this early action has been estimated to have saved tens of thousands of lives in the Bay Area alone. You're one of those health officers. Can you tell me, how was that decision made? How did you decide that you were going to pull the trigger before anyone else in the country?
Sure. It's actually a lot of great things about this story. I think we have a strong network within the Bay Area of health officers who have, while there's been turnover and movement between jurisdictions, a lot of us have worked together for a very long time over the last several years, including some work even in, the 2005 to 2007 timeline of preparing for pandemics, and then, of course, experiencing and responding to the 2009 H1N1 pandemic. So the weekend before, we'd also started having twice a week phone calls in the Bay Area just about the various issues we're all facing, and really being able to share a combination of lessons learned and thoughts about how to approach the various issues. So as many people may know, Santa Clara, certainly in California and in the Bay Area, was one of the first jurisdictions to have the first case and has been hit the hardest in the Bay Area. And that's a neighboring county to us in Alameda County and here in the Bay Area. And there were some other health officers, I think, that started having early morning calls on Sunday, just really looking at the rate of rise and the exponential increase in cases in those counties, and being really concerned and seeing what was happening around the world, and Italy and other places that had not intervened early enough. So they then, it was sort of San Francisco and I think Santa Clara got on the call with each other first, and then texted the rest of us, and we were on a call at noon discussing the situation, looking at the data again about the exponential rise in cases, especially in the sort of west side of the Bay, who had been hit first and harder, and also looking at a small community surveillance data that Santa Clara had put together too, showing that 10 to 11% of their patients that had a flu-like illness were positive for COVID-19. And again, just thinking about knowing what we know about community mitigation and how to prevent further transmission, we discussed that and decided that we really needed to act. And it was also compelling that Dr. Cody said she, almost wished she had acted even sooner. So I think we were just, and having those strong relationships as well, I think really helped us align around making a decision that we knew that every day would matter. And as you mentioned, I think that's really illustrated by looking at other communities and how each day did matter on the number of cases and deaths prevented.
Mm-hmm. Now, you're public health officers, you're looking at the science, but some people would say, well, obviously has a big impact on the community. Did you expect pushback perhaps from school boards or county boards of supervisors saying that, wait a minute here, you want to shut everything down? Shouldn't we wait and see what happens more?
We were definitely concerned about that. And the other quick thing I will say that was really impressive about the entire situation is that within 24 hours of us making the decision, and we do have that local health officer authority here at the local level in California, we were then on the call with our county councils in each of the jurisdictions to really work through the details of a legal order that we could issue with that authority. But we certainly had concerns, and I think that was the other great thing about being able to make the decision together and present the information together to the public. And by noon the next day, we were in front of, everyone sort of making this announcement together with our physically distanced press conference to show that we knew that together this was the right decision for our community to, again, prevent transmission and mitigate the pandemic and save lives. And we were also I was personally very grateful that there was not actually a lot of pushback then. I think people did see what was happening around the world and how this intervention at different timelines could make a difference. And thankfully as well, I think the media and others had started to socialize this idea of flatten the curve. So we had surprisingly little pushback early on.
Well, that's good to hear, but I think also it's probably helpful that you were able to act in concert, right? If it was,
absolutely.
Yeah, if it was one public health officer at a time, might have been a little more challenging than saying, look, our whole region, we all are in agreement and we're working together to make this happen.
Yes, absolutely. I think that's been really helpful through this entire time period that we've had these orders in place. And I think we'll get to this later, but yeah, I think it's been incredibly powerful to have us be able to speak as a region from the public health perspective.
Now, since then, we've seen the success so far. We're not over this yet, so I don't want to assume, but we've certainly seen the flattening of the curve, although we haven't quite hit the top yet. We're sort of plateauing perhaps right now. But since then, of course, various other studies have come out. More locally, there was a widely reported Stanford serology study of people in Santa Clara County that concluded they recruited people through Facebook. So there's some issues about how representative the sample was, and they did some statistical and analysis to try to even that out. But it concluded that many more people had been infected with COVID-19 than detected with the PCR testing. We know there was a shortage of testing at the time. There have also been reports of people who have died of COVID-19 earlier than previously reported COVID deaths. So I think they identified a couple people who, because there was no testing, but now in retrospect, have evaluated those deaths and have identified that they had died of COVID. What did these more recent sort of studies tell you, and how do they help inform your public health recommendations now? We also had Los Angeles, and I think New York's doing some of these population studies and so forth. So how do they help contribute to the decision-making and your evaluation of the situation?
Sure. So the initial study of the serology testing and the antibodies compared to PCR testing really spoke to what you just mentioned, which is that there's been a shortage of testing from the very beginning. And so we were not surprised that it was helpful to confirm that a much larger number of people had been exposed compared to who we were able to test with PCR. It also helped give us some estimates around how many people we think have been infected in the region. And, in looking at our overall testing now, I'd say the trend is, around 9 to 11%, or, it varies a little bit from jurisdiction to jurisdiction, but of the patients we are testing are positive. And so theoretically, the people we are testing have a slightly higher probability of being infected since most of them have symptoms. And it just helps us give some estimates of, we think, much less than that of the entire community at least have been exposed. And then to the other question about the early deaths, I think we absolutely were concerned and suspected that there might have been virus circulating much earlier, and this, again, confirmed that. There's some other studies as well, and we, again, did not see an overwhelming hospital surge early on, thankfully. And so we do think that virus is circulating early, and not surprising knowing how much travel we have from China. And specifically, we knew, numbers-wise, we were one of the largest regions to receive flights from the Hubei province in China as well, in the Bay Area, based on who we were monitoring as far as travelers early on. So, again, not surprising, but just helpful to us to move forward. And then the coroners and medical examiners in the different jurisdictions are now actually looking back to see what other deaths that have been reported, at least at our coroners' cases, and there will potentially be some retrospective testing there as well from mid-December that the state is actually coordinating, ensuring that happens, and collecting any data about that as well. I think moving forward, again, it just helps us know that it's that more people were infected than we thought as far as testing, but not a huge number. And we're having a lot of interesting conversations around how do we continue to balance protecting the community from this very concerning disease that can have very serious consequences, but also try to generate some, what we would call herd immunity, especially among those who are much less likely to have any serious complications, and also mitigating the impacts of not only the pandemic and the disease, but, now that we're several weeks into the shelter at home orders, the other sort of unintended health harms of our public health interventions.
Yeah. Well, it's interesting because you mentioned community immunity or herd immunity. Even the study in Santa Clara, of which some people have pointed to and said, well, look, we're having a lot of people getting the disease. Even that only said it was about 2 to 4%.
Correct.
And for community immunity, we're talking, 70%, 80%. There's been different estimates, but certainly a long way from 2 to 4%.
Exactly. And the other thing I'll just add, too, is there are the Chan Zuckerberg Biohub is helping fund a study, a follow-up study that will be in Stanford, UCSF, and San Francisco General Hospital, looking at patients from the 6-county region and doing some serial both PCR testing and antibody testing, and also looking at a subset of healthcare workers. So there's other studies that are about to be launched that will be happening over the next 9 months in the Bay Area that will help inform us as well.
Yeah. And I think the other issue that also comes up, though, is that with some of these studies is the inaccuracy of many of the serology tests that are being used. And we talked about that on a previous podcast on testing. And so as we're looking at serology tests, exactly how do we interpret some of these community tests, and what kind of serology tests are they actually using in terms of their accuracy and the sort of false positive rates that we've seen on some of these tests?
Yeah, I'm really glad you brought that up, because there's, of course, understandably a lot of public interest in that. And not only is the FDA approving a lot of things or allowing people to start moving forward before a lot of validation in the interest of innovation and making sure we have increased testing, but I think there are a lot of tests out there that are not reliable, especially currently the point-of-care tests. And then the other really important concept that is, I think, a little bit hard for people to wrap their heads around is that when you have a low prevalence, which these prior studies suggest, any current testing, even the reliable antibody tests, have a positive predictive value of about 50 to 60% if you think the prevalence is less than 5%. So it's sort of like flipping a coin. So I think it's really important that there are these strategic surveillance studies that are done in a systematic way. And I think currently the antibody tests are not necessarily going to be helpful to determine, for example, which people want to know, is this person safe to, be back out, amongst people and be exposed. And again, with the 50 to 60%, what we call positive predictive value, again, it's like flipping a coin to say if that test is really reliable in a low prevalence population.
Yeah. Now, we talked about how you went about establishing the shelter-in-place orders, but I think now people want to know, okay, well, what do we do to lift them again? So what are some of the things that you and your colleagues, you have the authority to place the orders, and we're looking at you and saying, well, what's the next step so we can start lifting some of these shelter-in-place orders?
Yeah, so what we have just done here in the Bay Area and actually issued yesterday is both a communication and an update on our orders. And one of the key things we are looking at is what are some indicators that we want to monitor, that we also want to share publicly so the community can follow along with us and help us reach our goals around indicators. But a couple things here that are looking promising are that the new cases per day do seem to be decreasing, and our hospitalizations are relatively flat over time, and our hospital bed capacity is actually quite good because there were so many elective things, canceled and things like that to make sure we had bed capacity in case we had a huge surge. So those indicators made us feel like we could loosen up a little bit on our local orders. We are, of course, under the umbrella of the state health officer order, and we'll continue to coordinate with the state on that. And we do have periodic calls with the state health department around that. And then the other indicators we are looking at are, in addition to just the sort of number of hospitalizations and the trends of that, but what % of our bed capacity is taken up by COVID-positive patients? Can our hospitals and clinics reassure us that they do have enough PPE for the next, for example, 30 days is one of our indicators. Do we have enough testing capacity to really feel like we're at the place where we're testing everybody who's symptomatic and we're able to test in our high-risk settings such as long-term care facilities and skilled nursing facilities and other outbreaks? And do we have the public health infrastructure in place to, as we loosen and anticipate seeing more cases, as there's more person-to-person contact, do we have the infrastructure to say that we can reach over 90% of cases and ensure they're safely isolated, and of those cases identify at least 90% of their contacts and make sure their contacts are safely quarantined? So we're looking at all of those indicators as markers that will help us show that we've made progress, and also as things slowly become more loose, are there any concerning direction of those indicators that mean we might have to restrict again? And again, needing to really closely align with the state, and they have released their sort of 4 phases of reopening, so we'll be working closely with the state on that as well.
So the governor did describe 4 phases. Right now we're in phase 1 with the stay-at-home orders. Then he talked about phase 2 with a basically a lifting of some places for activities. Stage 3 would be when you can have more general lifting, but no large events, right? And then stage 4 is, quote, back to normal, I guess, if you want to call it normal. So what do you think are perhaps some of the trigger points from you as a public health officer? I realize that this may be also decided at the state, but as a health officer, so what does it take to go from stage 1 to stage 2 and stage 2 to stage 3? You talk about indicators, but what kind of things do you actually need to see to go between these different phases from your perspective?
These are actually the indicators we're going to be looking at. So again, that we have enough PPE for the next 30 days, that our hospitals, are stable as far as capacity, that we have the public health testing and infrastructure in place to continue to follow up on cases and contacts. So we're definitely looking at these. And again, I think over time, we and the state are coming up with other sort of indicators and triggers as well. And I should also clarify, I think the way we're thinking about it in the Bay Area is that we had been a little stricter than the state from the very beginning. As you noted, we were prior to the state, and then what the state came out with had some areas that were less restrictive than ours, for example, all kinds of construction. So that's another thing we've allowed in the Bay Area. So we're kind of thinking of our phase as phase 1.5, and then looking at these indicators actually as triggers to, once we feel like we're definitely testing, actually one of our testing indicators that we've decided in the Bay Area region, which is aligned with some of the state goals as well from the testing task force, are if we can show that we're testing about 200 per 100,000 people in our various populations, we feel like that's an estimate based on a few different epidemiological studies and estimates on that might be a good estimate if we're testing everyone who's symptomatic and being able to test in our outbreak setting. So we're not there yet, and we want to really build up that capacity quickly. And again, as you mentioned, and as people have heard, we've had a lot of challenges with ramping up testing, but there's a lot escalating, every single day and every week, I think, here and statewide.
Okay. And finally, as a county public health officer, what are your top priorities and biggest challenges during this pandemic?
Yes. So, of course, my top priority is to keep people safe. And I think that the challenge on the other side of that is weighing, again, the harms of the pandemic and the harms of potential viral spread. And as we're learning more about potential chronic manifestations of this disease and, thrombotic and vasculitis-type manifestations, truly trying to understand what are the harms of the disease and weighing those with the harms, again, of our interventions and really looking at all of those with an equity lens. We know on both ends of that that our communities of color and our low-income communities are impacted, unequally on both sides of that, and really trying to monitor that as well and continue to strike that balance. So I'd say, we're making, as far as challenges in addition to that, really trying to make very difficult decisions with little data or a lot of data that has a wide spectrum of results. I think people may have seen, a lot of the modeling about where we are and the impact of social distancing and the surge capacity. There's a lot of great minds and models, and there's still a huge spectrum of where they land. So we really, I think as public health practitioners and as physicians and epidemiologists, we're really interested in being as evidence-based as possible, but making, these challenging decisions with knowing that the data is just modeling and that we're still learning every day about this disease. And also, of course, navigating, you alluded to this, but the politics and the realities of what everyone is facing and the challenges around that. And I'd say the last challenge is just that we're operating with sort of a under-resourced baseline public health infrastructure, so really trying to ramp that up to be able to respond to a pandemic in a situation of this magnitude.
Well, thank you so much, Dr. Pan, and I think this pandemic's a good reminder of the fact that public health is a vital part of our public safety infrastructure. I mean, it's being done on an ongoing basis every day with many other infections and chronic diseases and so forth, and injury prevention, et cetera. But I think the pandemic certainly highlighted the role of public health officers and staff and keeping us safe in our communities. So with that, I want to again thank you so much. Thank you for listening to this episode of Putting the Public into Health by Dr. Richard Pan. If you have any ideas or questions for a future podcast, please email them to senator.pan@senate.ca.gov. Please stay at home as much as possible. Stay at least 6 feet away from others outside. Wash your hands frequently and try not to touch your face. Together, we are slowing the spread of the disease and saving lives. Thank you so much for listening.